I'm going to go ahead and start the program. So good afternoon. My name is Karen Corman, and I have the privilege of being the Executive Director of the UIC Alumni Association. Welcome to the UIC Alumni Exchange Series. Through the UIC Alumni Exchange Series, we work to bring our alumni and friends a variety of programs and topics so you can explore, connect, and even escape from the everyday with a community of UIC alumni faculty, staff, and alumni experts. You'll hear me say this a few times today, but I encourage you to visit go.uic.edu/alumni exchange for the latest and greatest programming. And with that, I'm excited to start our program this afternoon as we are joined by UIC Associate Professor and Geriatric Researcher, Dr. Valerie Gruss. Taking care of our oldest generation can be extremely challenging. Dr. Gruss will share innovative approaches and how to use technology to your advantage as she discusses the future of aging. Thank you, Dr. Gruss, for being with us here today, and I'll turn the program over to you.
Thank you. Welcome to the future of aging, or how technology enhances older adult care across the globe. I'm Dr. Valerie Gross, a clinical associate professor here in the College of Nursing. I'm also project director of a HRSA-funded Engage Illinois grant. I'm also director of interprofessional education here in the College of Nursing and an AAN Edge Runner. I'm excited to be here today, and I appreciate the opportunity to tell you about some of the innovative, exciting work going on here at UIC. Currently, I have funding through the HRSA, Health Resource Service Administration, the Center for Disease Control, AWAN, and the National Institute of Health. I think it's important, and I would like to begin today by recognizing and acknowledging that the University of Illinois system carries out its mission in its namesake state of Illinois, and it includes all the ancestral lands listed here. We have a responsibility to acknowledge these native nations and to work with them as we move forward as a vibrant, inclusive institution. So let's get started and talk about the aging population. In the US, there are 318 million people. 46 million are older adults. So that's 15% of our current population. In 2020, for the first time in our history, there were more older adults and they outnumbered children younger than 5 years old. Our projected population increase by 2060 will be older adults will be 23.4% of the population. However, in Illinois, that projection is even greater. In Illinois, by 2030, which is just around the corner, we expect our older adult population to be 30% of our general population. Hold on just a minute. I will get this to go. There we go. Okay. So the question arises, is this a silver tsunami or is it silver lining? So ageism, and there are ageism and ageist stereotypes. The controversy is whether we view it as a silver tsunami or a silver lining. That depends on our perception and values of the older adult population. You should be aware that ageism is one of the last and persistent prejudices, and ageist stereotypes exist. As you can see from this word cloud here, these are the common adjectives used when referring to older adults: poor, frail, slow, forgetful, grumpy, lonely. So just as a silver tsunami and silver lining is used depending on your perception of aging, so are these types of adjectives. It's important, and there's an urgency that we change the narrative and we erase these types of stereotypes. I'm gonna keep moving this. There we go. There we go. So let's change the narrative on ageism and stereotypes. When we talk about older adults, we're speaking about the ages 65 years to 100 years old. And yet it's very different in each decade. A 65-year-old is very different from a 75-year-old, 85-year-old, or 95-year-old. Yes, yet we refer to all of them as older adults. When in our adult population in nursing in particular, when we're talking about adults, we consider a person who's 20 years old very different from a person who's 35 years old. Yet when we're talking about older adults, we seem to just collect them all together and talk about older adults. And we really should be considerate of the different decades and how populations are different. I wanted to include an example here. This is Julia Hurricane Hawkins, and she runs the 500 meter and the 100 meter at the senior games. And in 2019, of course, she's the gold medal winner for multiple years, but she continues to participate in the Senior Olympics, and she's 103 years old. So again, we can't make generalisms, and we can't think of stereotypes when we're thinking about older adults, because the variation among the health of different persons is the same as it is for younger people. So that brings us to the three primary changes that exist with the older population and in geriatrics. So what are the pressing challenges that we need to consider with older adults? And what solutions have we created? Three challenges that I've identified and have received funding and I'm doing my research with is, number one challenge is that increasing population we just talked about, while there's a decreasing number of clinicians who work in geriatrics. The solution is to provide online virtual geriatric training to educate the future and current primary care workforce in geriatrics. The second challenge is there's an increasing aging population which increases the number of older adults that have dementia, because we know that dementia, the incident increases as people get older. So it's important that we realize that with the older population, there's going to be more people with dementia. And we really need to get information on managing dementia and treatment and resources out to the general population. My solution was to create a mobile app and use that technology to change the way that information on dementia is disseminated to persons with dementia, families, and the general population. And then the third challenge, most vulnerable older adults are homebound and unable to visit clinics for in-person care. And the solution here is to implement telehealth e-visits with clinicians and home monitoring devices that do virtual status updates on patients in their home. So I'm going to talk about each one of these projects and how we met the challenge. Okay, so challenge number one is that increasing population and decreasing number of clinicians. So the number of healthcare professionals trained to provide comprehensive care for older adults has not kept pace with the older adult population. So our solution has been to create a healthy oldest population by preparing the general geriatric workforce and a current workforce and future workforce. This grant, this funding, this project was funded through HRSA. The federal government agency HRSA offered a geriatric workforce enhancement program. We were awarded this grant in 2015, again in 2019. And it includes for us to develop a model and a mechanism to educate clinicians in geriatrics and how to integrate geriatrics into their primary care. So our method was to use technology to educate faculty, residents, students about interprofessional collaboration and about geriatric practice. So we created an online accredited learning and interprofessional geriatrics program. So let's talk a little bit about what that looks like. Here. So the Modern Healthcare Journal says that they've been seeing a beginning of a convergence between devices and apps used by clinicians, but also those used by consumers. And we're finding that the general public or consumers are more and more utilizing technology to get their healthcare information. So we decided that we would create technology as a mechanism to reach clinicians, something that would be convenient and affordable, something that's evidence-based. And most importantly, we really want to offer flexible learning opportunities and to offer continuing education credits for licensed healthcare providers. And you're an example today using this type of technology to access information. So this is more and more common, and this is the mechanism that we used. So we decided to create an online geriatric course. Okay. The course is evidence-based. It has content on a variety of geriatric topics. And it's flexible, so you can go into the program at your convenience and take your modules, learning modules. It's free. And importantly for the learner, it offers free continuing education credits for medicine, nursing, pharmacy, social work, and occupational therapist. So this is a list of some of the modules in our online program. So our online program, you can access it through our website, engageil.com. And our online program has 27 different modules. And the topics range from general topics on elder abuse and self-neglect, geropharmacy, medication management, the geriatric assessment. And we also have 4 modules on dementia, but learners are able to go into the system and they can take one module or you can take multiple modules. Advance, hold on. There we go. So what's different about this? There's lots of online continuing education credits, right, that you can earn. But so what's so different about our module? Well, we took a little bit of a different approach. Our online modules are innovative in design. And each of our modules is a mini film. And we used a documentary film styling technique. We hired actors as narrators, and we use animation and infographics. And each module is evidence-based, and it was written by content experts in the topic field. We also included video interviews with content experts, and we also included additional video interviews, sometimes with case study patients who tell rich stories that engage the learners. So the outcomes for this program. Since the launch of our program, which was in March of 2017, over 18,000 online modules have been completed by over 5,000 learners across the country. Many learners take more than one module. The learners come from 49 different states. It includes urban learners and rural learners. And the learners include clinicians, faculty, and residents and students. So when people complete the modules, we do collect data, we do have a survey, and we do collect data to see the impact of our online program. And we have found that through the learner surveys that there is improved proficiency in the various topics, as you can see from this table. We also did some measurements on practice change. It was important for us, in addition to having the learners improve their knowledge about a specific topic in geriatrics, we really wanted to understand better what was the impact on practice change. Did it make a difference when people took the modules? Did it actually change their practice? Did the changes apply to their practice in caring for older adults as a result of participating in our program? And as you can see here from some of the changes, learners reported that they would use some of the personal anecdotes from the speakers and apply them to appropriate situations. And they will use all the websites and refer to the organizational resources. One learner reports they'll add this information in their treatment notes. They would incorporate some of the pharmacological and non-pharmacological interventions that were recommended in the care of the dying patient. So they gave a lot of specific examples of how they would implement some of the learning that they had into their actual practice and make some changes. We also measured the outcome on effective interdisciplinary teams, because it was important, because throughout our modules, we really have a focus on learning about collaborative team practice. As you can see, we offered our modules and you get continuing education credits for learners from all different disciplines. So we really had an interprofessional focus within the learning modules, and we really promote collaborative team practice. So here the learners describe their plans of sharing the module information with their teams and actually implementing team approach to geriatric care. So here they say, I will share this with staff at the hospital. I'm going to share this at interprofessional meetings. I will share the information with my team and create a list of areas that we need to work on to improve geriatric patient care. And then I would apply the information from the learning activity to any areas that need specific improvement. I'm going to send out a pamphlet or an email or include this at a staff meeting to provide education on elder abuse and when we're supposed to report it. So again, the learners were actually reporting actions that they would be taking to take the knowledge that they had from the modules and make changes into clinical practice. Okay, so now we're going to talk about challenge number 2. So the second challenge we address is the increasing aging population and the increase in Alzheimer's disease and related dementias. So my goal with this was to find a mechanism to educate the general public about dementia. And I decided to use mobile app technology. I believe that this would change the way the information on dementia is disseminated. And I also believed it would make it free and it would be accessible to people around the globe. Our focus was on dementia because the incidence of dementia increases as the population increases, and there's a great need. We currently have 5.3 million people in the US who have dementia. 60 to 80% of that is Alzheimer's disease, and the other 20% are related dementias. And those numbers are expected to increase with the increase in our aging population. And we expect by 2050, it's going to triple. And we may have 13.8 to 16 million people with dementia. So when we look at dementia and aging population, I just wanted to highlight how it's different for people at different ages of aging. I spoke earlier about the different decades of aging and how people in the different decades are different. And we see this with the prevalence of Alzheimer's disease. We see that with persons between the ages of 65 and 74, the incidence is 3%. And then 75 years to 84 goes up to 17%. And then over 85, it's as high as 32% of the population. And this is 32% that have at least some level of dementia. It could be early stage, middle stage, late stage. And what's the impact of dementia on our healthcare system, in addition to the impact it has on patients and families? Dementia is one of the greatest burdens contributing to dependency and disability among persons with dementia. And there's also a great cost to our healthcare system. We currently spend about $259 billion on dementia care, and we expect that to go up to over $1 trillion by 2050 with the increasing number of persons with dementia. At the current time, there is no cure or disease-modifying treatments for dementia. However, there is appropriate care for the potential of improving quality of life. And this is important because although there's no cure, we need to have a dementia positive approach. And there's many things that we can do to assist people to manage the dementia and to improve their quality of life. And also, most importantly, to support family caregivers. You know, just as we approach other chronic diseases that actually lead to mortality, such as heart failure, we need to focus on management of symptoms and enhancing the patient's quality of life and supporting family caregivers when we're addressing dementia. Because dementia is a chronic condition, the typical life expectancy after diagnosis is between 6 and 8 years, but many people can live up to 20 years after diagnosis. So this is a chronic disease that requires management. It is important that that management be dementia positive, and it focuses on quality of life. So why a mobile app? Between 2019 and 2020, there were over 250 million daily app downloads. That's huge, right? 500 million people were using healthcare mobile apps, and this is back in 2015, and that has increased. So mobile apps are a mechanism to connect with more people and to connect with people related to healthcare. Apps and devices are increasingly being used by clinicians, but they're also being used by consumers. Modern Healthcare, again, reports that we're seeing the beginning of this convergence between devices and apps that are used by clinicians, but also those that are used by other consumers. This is a mechanism for reaching the general public with evidence-based information, which is convenient and affordable. So how do you design a mobile app? Okay, I have to admit at this point that I am low tech. In fact, when my app programmers had our first prototype available and they sent me the link and to tell me how to download it, I was unable to do so. So I needed assistance to do that for my own app. But again, I'm the content expert, so I was able to develop it. Before creating the app, what we did was we conducted a needs assessment to see what was out there. And what I found was that most Alzheimer's disease or dementia apps were pretty much related to memory games that people could play, and that there were no apps that were evidence-based or created by dementia experts, at least none that provided information on how do you manage dementia, how do you communicate, what are some of the communication techniques for working with someone with dementia. And there were no apps that had links to resources and support services to address the needs of the person with dementia and families. So once we decided that there was a need, our next step was actually to develop the concept. So my concept was to develop a dementia app that identified practical steps or to guide the person with dementia and families through the dementia experience or journey. So the app was created with content expert, and also the technology portion and programming was done with University of Illinois app developers. So when we were developing the concept, what we did was we knew that, being a dementia expert, I knew that the dementia journey typically takes people through certain steps. And the first step is where they question, well, what is dementia? They need to know what it is. And then the next step is, how do I get diagnosed? How do I get treated? And then another step is actually living with dementia. And then another step is planning for the future. What's next? And as you can see, this is an image of my app. And as you can see, this is the home page. And we have those 4 steps or stages. So people can just click on one of the stages depending on what their interest is, and they can go to that section of the app. And it was important also when we were designing the app that it had a lot of visuals and images because we found that it was easier to navigate for people. So once we had the content written, I think we were at prototype 12 at that point, we decided that we would beta test the app with seniors at a senior center. So we went to a senior center and we handed out, without instructions, we handed out mobile devices with the app loaded on it. And we observed the seniors to determine if the navigation of the app was intuitive or not. And then following their use of the app, then we did ask some deliberate questions, such as, what was interesting in the app, what was important for them, how was it useful? And they told us that they really liked the images and they thought the content was important for everyone and it was useful. And then they had some recommendations. So the app was modified to include an option to access information through book style chapters. So let me talk a little about that. So this is one of the changes that we made to the app. The seniors had mentioned to us during our beta testing that they really wanted to use the device more at like their Kindle, that it would be easier for them to navigate if it had chapters. And so we went back into the app and we went back into our content and we actually devised a table of contents that had chapters. So every section of the app had a chapter. And so then the seniors were able to, they had the option after the home page to go to the table of content and click on a chapter they may be interested in, or they could click on the images. So they had the option to do either one. It was a little difficult in the programming to go back and forth with, but the app developers were able to do that. And we found that a lot of seniors like this format better. And our ultimate goal was that we wanted to develop something that would be practical and useful and would address the needs of that population. So after prototype 17, we were finally able to launch our app, and this is where we are now. And so the app is called Dementia Guide Expert. And again, because it's a guide to take people through the dementia experience. and it's written by content experts. So that's where the name came from. The app is available. You can download it for free. It's available if you have an iOS device. You can download it at the Apple iTunes Store or the Apple App Store. If you have an Android device, you can download it on Google Play. Following the launch of the app, I think it was about 2 or 3 years after the launch, we were contacted by some Spanish-speaking organizations in Chicago who had found the app and told us that there was nothing like this available for the Hispanic community, and that they really were wondering if we could possibly translate it into Spanish. And so we did. This was a year-long project. We found translators and we translated it into Spanish. So you can download the Spanish version if you like. If your device your phone is in Spanish, it'll come up in the Spanish version. The following years, we were contacted by a Korean organization also asking us the same, if we would translate it into Korean. So we spent a year and we had translators and we translated it into Korean. So, our goal was then, after we found that there was such a need, because there wasn't a product like this available to persons with dementia and families, and that there was such a demand for it. So we had planned to translate it into other languages. And the next language we had chosen was Mandarin. We thought we would go, for the Chinese population, that we would do Mandarin, but we've been a little diverted for 1 year. Let's tell you about that. So this is where we are at now. When you develop a mobile app, you're able to collect app data analytics. And it was important for us that we know how many downloads and views there were of the app, and also where was it coming from? Because we did a little bit of marketing. We would go to conferences and we would hand out flyers and do some marketing of our product, but we really weren't doing deliberate marketing because we thought we needed to know, where's our audience and where do we need to go with that. So what we have found, our first English version was launched in December of 2017. And as of January of this year, the app has been downloaded and viewed over 56,000 times. And that's in 12 different countries: Australia, Brazil, Canada, China, Germany, Japan, Korea, New Zealand, Spain, Taiwan, the UK, and the US. And we found that 83% of our users are using an iPhone and 17% use an iPad. So this is important information for us. We chose not to collect any other data at this point. We haven't asked people to submit any personal information. We felt it was important that they can just go in and use the app when they like it. And so this is only the data that we were collecting. But you're welcome to go ahead and download it for free. So as I mentioned earlier, our plan was to go ahead and translate into one new language each year. But this year, we've been working with the Center for Disabilities, and we decided that it was very important for us to go back and redesign the app and make accessibility features for persons with disabilities. So we've been spending most of the last year on some design changes. So there's going to be an icon when you open the app, and you can go into that icon, and there's multiple features that it can enhance the text, the type, all different features. So I think there's about 9 different accessibility features that we're adding. So you have the option to add them or not. But we've been working with the Center on Disability. It's really important for us that we do this, that the app be available to persons with disabilities. So this year, we're spending our funding and our time on this feature. So hopefully by the end of 2021, we will be launching the disability features. And then in 2022, we plan to move forward with other languages. Okay, so now we're going to go into challenge number 3. So some of the most vulnerable older adults are not able to visit clinics for in-person care. This necessitates increasing the range of community services provided outside of clinics and outside of hospital. So our solution to this, and this is where I'm really talking about older adults who are homebound. So these are persons that they're not able to leave the home and that they're not able to go to the clinic. So our solution was to implement a telehealth program in underserved communities. We realized that telehealth exists for persons who have the financial ability to have a device in their home, or they have internet, or they have an iPhone. But we thought it was very important that we implement telehealth in underserved communities where they may not have internet connections and they may not have an iPhone. So we implemented a telehealth program for homebound older adults in an underserved community, and we included daily health monitoring devices and also e-visits with their clinicians. So this part of my work was funded by HRSA again, but it was a special funding that came through during COVID-19, and it was called the CARES Act, COVID funding. And this part of the CARES Act was for 1 year funding, and it was for a new pilot telehealth program. And you could have used it with different populations, but we chose to use it with homebound inner city older adults who are extremely vulnerable population. So the objectives of the telehealth program, we had 3 objectives. First was to prevent and promote the use of telehealth technologies to reduce the risk of COVID, and then enhance the readiness to respond to COVID-19 through telehealth technologies by monitoring, and then to respond by providing access to telehealth technologies to limit the spread. So we had a COVID-19 focus, but it was also important that we were really addressing a need in an extremely vulnerable population. And even at the end of the funding, we have continued with the telehealth program among this population. So a little bit about the program. The telehealth program, as many of you probably know, that telehealth visits during COVID became essential because people were not able to go into clinics that were closed and access a lot of care, so that they really, their providers were connecting with them through technology, whether it was an iPad, a device, sometimes a phone call if they didn't have devices, but they would have an e-visit, electronic visit with their clinicians. So our program does have the e-visit feature, so the clinicians were able to connect with them. But what was different about our program was that we installed home monitoring devices into the homes of these homebound older adults, which have virtual daily check-ins with the patient. This program required us to do telehealth training. We had to train the clinicians, we had to train the patients, and many times we had to train the caregivers and families. So this is just a little image of what this kind of system looks like. And this is for the virtual patient monitoring. And as you can see, you have the device in the home. Our device looks a little bit different from this, but you have a video camera where we can see the patient themselves, but we also have all of these devices. So for our program, we partnered with a company called C24, and the devices that we chose for our patients included blood glucose monitoring, spirometer, blood pressure device, and ECG. So these are the devices, depending on the patient's needs, that were installed in the home and connected to their monitor. So let me give you some examples of some of the patients. So if we had a patient and we also did weight. So if we had a patient with heart failure, it was very important for us to do daily weight monitoring and blood pressure monitoring. So the patient would get on the scale, and the scale was connected wirelessly to the monitor, and it would record their weight. And then that weight would be transmitted to the clinic in their daily stats. And we would also have them put on their cuff, and they would do blood pressure monitoring at the same time. So those daily readings would go into the clinic. So I'll tell you in a minute, I'll tell you where it went from there. Or if you had a diabetic patient, we might want to just get daily blood glucose levels on them. So they would be doing their blood sugar readings every day, and those would be transmitted to the clinic also. It could also be used for emergency situations. If we had a patient that wasn't feeling well and called the clinic, we could have them check their blood pressure or check their blood glucose, and then the readings could come in right there directly to the nurse. But this is the things that we used. Okay, so this is the home monitoring devices for complex patients. This is actually the company that we use, they're called C24, and these are their devices and what they look like. They have all different types of devices. They're really portable. They're easy to handle. It was very important for us when we contracted with them that they had an understanding of the older adult patient, because many times the older adult patient, they might visually have difficult reading small print, or the colors, would be blended in and they wouldn't be able to see the readings. They may have trouble actually getting on a blood pressure cuff at the upper end of their arm, but they could do a wrist, they could do a wrist cuff. So one person we're using right now, several people are using wrist cuffs because it's really hard because of their disability. It's hard for them to maneuver and manipulate and get the other cuff on. So, but they were, what we found with this company, we were happy with them because they really had an understanding of that. They had done a lot of this type of work and they really knew what would be best for our clients. And we were able to pilot test several of the devices with some of our most complex patients to see which devices could actually work for them. Okay. So this is actually the data collection system that goes on. So this is what's going on. So you have the patient here on the left, and they do their daily weight or they do their daily blood pressure. Here it shows a phone device, but we actually had like Chromebooks or iPads that we used. Then you have the measurement, and it comes into the server and it gets recorded into the EMR, the electronic medical record. And then in our clinic, we also have a nurse that's reviewing the daily readings that are coming in. Now, in addition to the nurse reviewing the numbers that are coming in, we also are allowed to program each device for normal ranges. And what I mean by that is we could program it for a particular patient and say their normal blood pressure is okay if it's as high as 150/90. If it goes higher than that, we actually get an alert or an alarm system that it alerts the clinic that there's an abnormal reading. And it also can be connected to the physician's phone or the provider's phone. So there's lots of ways to alert, because with some patients, we don't want their blood pressure to be over 120/80. With other patients, they will never be, that's never normal for them, but we can set the parameters of it, what normal is for them. Same with blood glucose readings. We can set what should be the normal and the range for a particular patient. Should it go over, we get an alarm alert, and otherwise the daily stats come in for each patient. The other thing that the system does, which is nice, is it actually creates graphs and diagrams within the EMR. So when the provider is going out for a home visit or an e-visit with the patient, they have all of the readings mapped out for them because they can see where the abnormals were. So they can tell every morning you're doing great, but around in the evenings, your numbers are really going up. What's going on? Are you consuming something differently? Are you taking the readings at the wrong time? So they can really troubleshoot and see what's going on. So this is something like the monitor system that comes in. So we actually get these type of graphs that show the normal range for that person and where they fall on the graph. And then we have, this is the people in our centers, and they're actually seeing the patient, and they're actually reviewing the readings also. And then they also can see when the patient's next visit is, and if they're having some high readings but not abnormal, they might want to set an appointment where the provider has an e-visit with them sooner. And then we have the e-visits with clinicians. So our providers are able to do e-visits with all of the patients that are connected to the system. And finally, they're going back and doing some home visits in person, but they're also able to do e-visits too through the system. Oh, good. Okay, so we're going to have time for question and answer. So my Engage Illinois program has created an online geriatric training program. It's engaging, accessible. We found that it improves learners' proficiency and confidence, and it's really had a positive impact on practice change and interdisciplinary team training and collaboration. So I believe this online interprofessional education and collaborative practice program is helping to develop the future geriatric primary care workforce. The second thing is my Dementia Guide Expert mobile app. And this is transforming the dementia experience by guiding clinicians, persons with dementia, and their caregivers as they navigate through the trajectory of their illness and through the dementia journey. And then third is using telehealth home monitoring devices and virtual e-visits with clinicians to provide the care to the most vulnerable populations, those who are unable to visit clinics, and also those populations that are underserved. Oh. Great. So thank you very much, and I'm happy to answer any questions.
Well, thank you, Dr. Gross. This is incredible work that you've been doing, and I applaud you for all of these efforts, and thank you for sharing all this with us. We did have several questions come in, and you just spoke to this a little bit with your three-part summary, but one of the questions was, how can we help increase interest in the geriatric discipline?
I have been, as a faculty member and as a clinician, a geriatric nurse practitioner for decades, and as a researcher, I've tried to increase interest in geriatrics. And what I tell my students is that it's such a rewarding specialty to work in because it involves not just the medical model, but the psychosocial model. And as nurses, it's really important for us, and we all want to give holistic care, and many of us say that, but we don't see that in any other specialty area as much as we see it in geriatrics. Because when we're working with the older adult patient, it's really important that we're required to consider their environment. Where do they live? How are they getting their meals and their medicine? And how are they getting resources? Their families, their caregivers. So it's really important for us to include the whole patient. Because in geriatrics in particular, they might be prescribed a medication to help them, but we need to consider all the other pieces. How is that person going to get to the pharmacy? Can they afford their medicine? How much is it going to cost? Or do they not fill the medicine because they can't afford it? So it's all of these psychosocial conditions that we need to think about. And so it's the most rewarding because we can make the greatest impact. So I find it very challenging and different every day, and a very rich practice because my geriatric patients come to me with these rich histories, and it's just so rewarding to provide care to them. So I've tried to promote the geriatrics and working with older adults. This year, I was just awarded found out a new grant that's going to be a scholarship to encourage nursing students, and we're going to be providing a scholarship for nursing students to do geriatric care. So we're going to be doing some geriatric training of nursing students, undergraduate nursing students, and we're hoping that by doing that, they will develop an interest in it and want to work with older adults. And I think that's true also because, I'll get to your next question, because what I found over the last many, many decades as a faculty member is that when we bring students to levels of care where they interact with older adults, those are the students that will go out into practice and want to work with older adults when they have the experience. But and many times it's important for us to take our students not just to the inpatient hospital, let's take them to the senior center where they can really engage with older adults, and it's fascinating and fun, and take them to a health fair where they work with older adults. I bring students to health fairs, and then they really develop an appreciation and an interest. So I think through some of those experiences, we can really promote and make students interested in working in geriatrics.
That's wonderful. Thank you. And my gut tells me that anybody that takes courses with you, any of our students that take courses with you probably are influenced just by your passion around working with our older generation and the geriatric population.
Thank you.
Was there any follow-up to see if the participants implemented the activities they suggested they would?
No, what we did was, because there were so many learners that completed the modules, we surveyed them twice. So some of them we surveyed immediately after they finished it with what their intention was, and it's different. So what is your intention to implement these practice changes? The first year, we did go back to some of the learners and ask them if they had implemented some of the changes. We did a follow-up, in other words, to people that completed the survey. But after the first year, we did not. Part of it was our time constraint. We started to get so many learners in this project that it took so much time to just continue to have the modules running. We've also had multiple other universities, 2 out west and 1 in the east, that have adopted some of my modules because they don't have geriatric content. They don't have this type of content, and they really wanted evidence-based content for their students. So we've had a surge this last couple years in people taking the modules. So we haven't had the time to develop that, but it would be interesting. And it would be interesting for another reason, because I don't know if they need a booster, booster kind of module. At first we did go back and say, oh, you're a social worker. You took this module on elder abuse and neglect. Would you be interested in this other module? Because so many social workers take it. So we tried that for marketing, and that was working. But then because of the huge interest, we had to kind of let that go because we didn't need to do more marketing. But it would be interesting. I wish we had the time and funding to dedicate to that.
There's so many directions this could and should continue to grow.
Yeah.
There was another question about how are the patients selected to participate?
For the beta testing, for the beta testing, we just chose a senior center. And when we went there, we had iPads set up with the app on it. And we just handed them out to whoever wanted one. They didn't know what it contained. They didn't know anything about it. And we just would open the app and we would just say, see if you can use this. Because we didn't want to bias what they were doing. And we didn't want to prejudice anything they were doing. We wanted to see if it was intuitive. If someone downloaded it, would they know what to do? So we just went to one local senior center. It actually was in Oak Park. And they had about 50 seniors that day. And most of them did participate. And then after we watched them navigate and we just observed, and this was the app development team also, then we sat with them and did individual interviews and asked them those questions about what did they like about it? What did they find difficult? Would it be of interest to them? So then we would ask them specific questions. But initially, it was important that we just see, we're just going to simulate what this would be like if you open the app on your device and what would you do with it?
My assumption is that patients probably very much enjoyed participating in this too and being able to give their feedback and interaction.
Oh, yeah. After we had done it, many of them say, where can I get this? Where can I get this? And we're like, no, we're still on our prototypes, but we'll let the senior center know as soon as it's available, and it'll be free, but they were all asking, how can I get this on my device at home? Yeah, they were all asking that. Yeah.
Oh, wonderful. A little bit of a follow-up, I think. The participants for the telehealth grant were chosen based on what criteria?
Okay, the participants here, they were part of the UI Health home visit program. Department of Family Medicine here at UIC has a home visit program. And the home visit program is for homebound older adults in the inner city, low income, disadvantaged homebound older adults. So they've been running the home visit program for several years. And so we were able to use their patients. And one of the reasons also is that they weren't able to connect with their patients. Keep in mind, these are providers that were going out every week, every couple of weeks to these homebound older adults for years. And then COVID hit and these people don't have internet. They have no ability to connect with them. Some of them have phones, but they only have like a landline old phone. And even with that, it was hard for them to listen and understand the provider's instructions. There was no way to assess them at all, even through a phone call. So it was very, very difficult. So it was so important for that program. And we picked that program because they work with the underserved. And there's lots of, as I mentioned earlier, there's lots of telehealth programs that are available to people who have the means to have technology in their homes, but there's very little that's available to persons who don't. So it was important for us. Can we create a practical program that is beneficial for this type of population? And we're able to. And even with the end of the grant, we have continued the telehealth program. Yeah.
Oh, that's wonderful. A bit of switching questions, and this is a big question. How close do you think we are to a cure for dementia?
I know there's a lot of publicity about the new drug that came out, the Biogen drug, and there's a lot of controversy about it. There is no magic bullet. I don't think there's one coming down the road either. And the new drug that came out, this is my personal opinion, has nothing to do with the manufacturers of the drug. I really believe there were a lot of serious side effects, including bleeding and other things. And when I looked at the study, the results, I didn't see that it didn't make any difference in the actual outcome. That drug, the purpose of that drug is to prevent dementia from developing. And there's no way to measure if you're preventing it, because you don't know if that person would get it anyway. So how are you preventing it? They can give it to high-risk people who are at high risk for dementia, but there's really no way to measure prevention. Okay. So I don't see that. And as far as other drugs, because dementia is a complex disease and there's so many things that are going on that the research, there's a lot of millions and billions of dollars of research is focusing on different things that are going on in the brain. You know, the plaques and tangles that develop, there's, so many different mechanisms in the brain that happen as the brain deteriorates. So they're looking at drugs that stop one of these other pathways. So they're working hard on this, but I don't think there'll be a magic pill. I think what's really, really important for us today and over the next several years is that we really focus on approaching dementia the same way we approach other chronic diseases, in the sense that, yes, you have heart failure, yes, you have dementia, yes, you have diabetes, however, or yes, you have cancer, but with some of those, there's treatments, but some of them there's not. We know with heart failure, eventually you will succumb to heart failure. But during this time, we can improve the quality of life. We can certainly manage your symptoms. And we can give you a safe environment. We can help the caregivers cope with the stress of what's going on and the changes that are happening. So I think it's very important. I do a lot of dementia training. I work with the City of Chicago Age Friendly Commission, and we go into senior high-rise buildings and train the building management staff to assist people. And so we do other programs too. And our approach is, what do we do now for the people who have dementia and are living, and their families, and they're living through this? And there's so many things we can do. So that's what we're doing. And we have a very dementia positive attitude. And if you download my app, you'll see I have a lot of non-pharmacological approaches that you can use that really enhance the life of people with dementia. So I'm a big proponent of the non-pharmacological approaches.
Oh, it's just incredible. I have two last questions. One, which is a follow-up to the previous question. Somebody had asked, what outcomes did you track for the telehealth program? And are they written up somewhere where that could be shared?
Okay, the telehealth program, we did a lot of data collection. We haven't published it yet, but we're in the analysis phase of it. So what we've been doing, we did a pilot. When we started, we did only piloted with 10 patients because of the complexity of training these patients to use the devices, and also the challenge of getting all the results to come into the EMR. Because as you know, UIC changed over and we changed our EMR system. This is right before we launched the telehealth program. So we had to work with that. But we have been collecting a lot of data. What are we collecting? We're collecting outcomes. We're collecting, in addition to like all the readings, what we're also looking at is, what about hospital utilization? Because we believe, our hypothesis is, if we can control and stabilize their everyday symptoms, they'll go into the hospital less often. They'll utilize hospitals less often, less emergency department visits. So we're monitoring that. One of the other things we've also looked at it's a psychosocial aspect, of course, because I thought it was important. A lot of the older adults that are homebound, and in particular during COVID, is that they are socially isolated. So we have been measuring them for social isolation. We use the Duke Social Isolation Scale. And since prior to the start of telehealth, we measured them for social isolation. And then every month that we implemented the telehealth, and they've been connected with the people in the clinic and sending their results in and someone calling them, we're monitoring them for social isolation. And we're hoping that through the devices and their connection with the clinical staff, that it will improve their social isolation. So we're also measuring them for psychosocial things. So we're doing that too, but we're measuring them for lots of, we have a lot of data, but we're in the analysis phase.
Several times through your presentation, I keep wanting to say, wow, I'm so amazed at all this incredible work that you're doing, and thank you for all of it. I have one final question, which you touched upon, that there was I think you said a new scholarship coming in to help promote students to go into geriatric care.
Yes.
So somebody had asked the question about, would it help to support student scholarships in gerontology?
Yes, that should be coming out. We're just waiting the grant funder, the federal funder. We just found out last week about that. So I'm not sure if we're going to be offering the scholarship for the spring 2022 semester or this fall, if they want us to speed it up. I'm not sure which it'll be, but announcement will come out to all undergraduate students, RN, BSN students, and that'll come out soon. And we will be, the announcement will come out, students can apply, they're gonna go through, we'll be recruiting, they'll go through an assessment process, an independent assessment, and then I think we're gonna be able to offer like 40 scholarships over 2 years, which will be great. So what we're gonna be doing with the scholarships is we're gonna be giving them financial assistance for their nursing, the tuition. But the requirement is that they attend workshops with us on geriatric care and compassionate care, cultural humility. So we're introducing all these important topics, but quarterly they have to attend workshops. And because telehealth is so important for older adults, we're going to send them to a certification school. So they'll be taking an online telehealth certification and they'll get certified in telehealth.
That's wonderful. And if any of our participants are interested in donating to those scholarships, we can certainly provide that information to do that. Thank you, Dr. Gross. This has just been incredible. Thank you for your research. We're so proud that you're on faculty at UIC. Thank you for sharing the time with us today and all of this wonderful information. I highly recommend that everybody downloads the app and researches more and learns more. But thank you. We're very grateful.
You're very welcome. Thank you for the opportunity to speak to everyone.
Just to quickly close out our program today, please join us for our next Alumni Exchange event, which will be on Thursday, July 15th at noon Central Standard Time. We'll be joined by UIC alumnus Eric Meredith. During this hour, we will explore how health professionals observe cultural cues to learn more about the customs and practices of their clients to provide the best care possible as he presents food and health, improved nutrition interventions. To find more about this program and a recording of this program or any of our upcoming or past programs, please go to go.uic.edu/alumni exchange. And of course, please be on the lookout for that brief survey I mentioned at the beginning. Thank you again, Dr. Gross. We're very, very grateful for you. Thank you all of you for joining us today. We hope you have a wonderful rest of the day, and we look forward to seeing you again in a future UIC Alumni Exchange program. Thanks so much.
Thank you.